All right. Well, looks like we have some folks starting to file in here for the webinar. So really thank everyone for their attention, and thank you to our speakers and moderators today. We have a very interesting and different topic today. You know, we're not talking about the latest and greatest intervention, the latest and greatest publication, but I think this impacts essentially everything that we do, all of these things and technologies that we want to offer our patients. It all starts with talking to our patients about it and getting them to really consent for the procedure. And what does that all involve? So I think this is a really vital concept that really affects everyone in all aspects of medicine. And we're going to spend the next 45 minutes to an hour really discussing that with some experts on the field, and also then talking about some new technology to hopefully answer some of these difficulties that are going to arise today. Tim?
Dawa, thank you. Here's our agenda for tonight. You can see below me here on the slide. And I know many are joining us tonight, but we'll have many more join us over the next month on the website, and it'll be available there. I think, this has been an important topic for a number of years for me. And we have this responsibility to inform our patients about the risk of the procedure and the elements of what we're going to be doing and what the options are if we don't do that particular procedure. And then despite our best efforts, I read a study that would amaze me, that over half the patients don't retain what we say many a time, even if we give them great effort. And a lot of times patients don't even really care if they even hear informed consent, but it's still our responsibility and our duty to give them informed consent so they understand at least what our intent is. And I think that because of that, we want to really try to improve on this informed consent skill. We want to make sure patients are as informed as we can make them. And there's new technology that is out there that really may be an option for patients. And that's what we're going to talk about for the next hour. And I think it's going to be a really important hour, whether you be a physician, nurse practitioner, nurse, or you be a patient. So I think this is going to be a great discussion. And to lead that discussion tonight, we have an amazing young man, Professor Osman Latif, who's going to kick us off and really talk a little bit about best practices and new technologies. So with that, Usman, we'll give you the podium.
All right, thank you so much. So I wanted to just kind of get started by getting into the overview of why this is an important topic. There we go. All right, so informed consent, Tim talked a little bit about some of the reasons why it's such an important topic. It's really important for transparency with patients. What are we going to be doing? What are the risks that come with that? But it also sets expectations, which means that it's going to improve the flow of your practice, right? If patients know what to expect, what the procedure is going to be like, what kind of things they can expect afterwards, that's great for everybody. But the other part is that it's also a critical part of managing risk. And especially in a specialty like ours, where we're so procedural, this begins to be a larger and larger problem as you kind of go on with your practice. So I wanted to talk a little bit about three components of this. So when we think about what is that risk, right? What is that risk for us? There's this great study from the New England Journal of Medicine from MGH and Harvard, where they looked at about a big database of malpractice data to try to figure out what that risk looks like for physicians in any given year. And what they found was during the study period, every single year, physicians have about a 7.5% chance of having a malpractice claim. And that was a lot higher than I had expected. And that by the age of 65 years, in high-risk specialties, which would include our specialty, 99% of physicians have had at least one malpractice claim. So now we know that it is, unfortunately, nearly an inevitability, and that this risk accrues over time as you continue on with your practice. But what is the etiology of these claims, right? What leads to them? And so there was a good study in JAMA Surgery that looked at this, and they looked at a medical legal database looking about 35 years of claims, and they tried to figure out what leads to most of these claims. And what they found out was that informed consent was the most significant allegation in these lawsuits after spine surgery, and that in two separate surgeries of malpractice cases that looked at cases where spinal surgery was involved, more than 50% of suits cited informed consent as the basis for the lawsuit. And in fact, in this study itself, where they looked at about 35 years of malpractice claims from this database, they found that almost 66% of the claims were related to informed consent. And I think this is a good corollary, right? Any of these studies that look at a high-risk specialty are a pretty good corollary for our specialty itself. So now we see that it's a high likelihood of having some type of malpractice claim, that most likely 2 out of 3 of these are going to be related to informed consent. So what can we do about this? What can we do to improve the process for patients and to minimize this risk? Well, we want to improve patient transparency by giving them more information about what happens with the procedure and what kind of things they can expect. And we're gonna frame this discussion with this product called Informed Consent, which essentially provides patients a tablet-based solution. So they come into your practice, you give them this tablet, and you pick the procedure that they're going to have. And then it tells them everything about the procedure. There's animations that show what the procedure will be like, so they know exactly what to expect. They know what it's trying to accomplish, what the anatomy looks like. They know what kind of complications are possible and how likely they are. And they also know just kind of what to expect post-procedure, as well as what the alternatives are. The really great thing about this is that it creates this legal record that perseveres. So this is an example of how it works. And you can see up here on the top right is one of my nurse practitioners, Katie Fry, who was the very kind model for this. And essentially it uses this AI technology so that it tracks your face and eyeballs. And so as you're watching this video, if the patient starts to lose interest or look away, it will pause. And then it won't pick back up until they start to pay attention again. And all of this is saved as kind of a persevering legal record. So you have a record that not only was this very comprehensive informed consent provided to the patient, but that they actually watched the entire thing, and there's a video of them watching it. And then once they complete this in its entirety, then they are taken to a written version of this, where they sign a consent digitally that outlines all of this in writing with all these different risks. And so now the data has been presented to them both in video, audio, and written form, and in a way that everyone can refer back to in the future. So I think this is a really interesting product, both from a standpoint of kind of helping mitigate this risk, but also from a patient standpoint. You know, this is great for patients. Anything that's good for patients is good for us, where they're going to have a better knowledge of what's going to be happening on the day of the procedure. And this potentially can lead to efficiency gains as well, because you can provide them a lot of data that's kind of automated and then come in to answer the questions that they might have. So I just wanted to give that as kind of a brief summary to kind of show you what we're going to be doing today. And I'm going to hand that back off to now Dr. Koo, who's going to talk about some other things related to this.
Thanks so much, Usman. I think you teed it up very well. You know, as in your paper that you showed, obviously spoke specifically in JAMA about spinal surgery itself. As you know, spinal surgery and neurosurgery as well are one of the most highly litigious types of surgeries that we can perform. And as you commented on the same study, that the correlation between an informed consent and protection and a judgment ultimately in favor of the physician, and also on the ultimate amount of damages that were awarded, 2 cases that were awarded to the plaintiff, also had significant direct correlations to informed consent. And I think that's very, very important. But also, if we kind of cone down in the paper, one of the things they said is that the 24-hour recall, or as you were pointing out earlier with the informed consent video, the retention and the concentration and the understanding of the patient is often the most complex feature of the informed consent process. In fact, in that same study, they found that only 60% were found to understand the purpose of their treatment, or put more simply, only 60% 24 hours later remember what surgery or procedure they were scheduled to have at all. And of them, only 55% could even list one potential common complication. So you can see that the process of informed consent, as you laid out, is actually very multifaceted in the sense that A, it's actually doing the informed consent, providing them with all this information, and A, improving their 24-hour recall. And so repetition, of course, would be an obvious point. And finally, most importantly, trying to find ways to improve their satisfaction with the informed consent process, because it's not just what they remember or what they understand, but also how they feel that the physician interacted with them, and did the physician seem to give a willing, strong effort to provide them with informed consent. And that also strongly correlates with the chance of litigation and also the litigation outcome as well. So if we cone down and look at neurosurgery itself, JAMA was a review article. This is a paper actually published out of Northwestern from one of our old fellows, Sandy Lamb, who looked at did a very good meta-analysis review of the literature looking exactly about this, specifically on the points of what I talked about earlier: recall and documentation of the encounter and of the consent experience. And they found that overall, baseline attention recall, just like the JAMA article, was found to be extremely low. And particularly when it came to medical risks, which are particularly relevant when we're talking about surgical complications and alternatives. That decreased the most in the patient's memory over time in a very rapid fashion. Cognitive impairment was also noted as a factor, meaning the education and the cognitive ability of the patient. But this article focused more on the things that we can do to improve on that. And the top 3 things that we could glean from this very large meta-analysis by Sandy, our old fellow, was that number 1, digital consent with bullet points is very critical. Long paragraphs and long speeches have very poor retention, whereas bullet pointed type of consent processes and information kind of packets with places where we can check off that that information was delivered and the patient can sign each step along the way to say at least they read it, or in this case watched the video and understood, were important in determining the overall success of the process and improving 24-hour recall. Also, the consent process has to try to engage the patient support system by involving as many of the patient's family, friends, and support network to help in that shared family recall. So having the portability of the video document, as Usman was saying earlier, can greatly help to improve that process because they can review it several times and with other people, and they can send it to family members in other parts of the country. So it's a collective consent process of the patient and their support network, not just of the patient in the doctor's office. And finally, what Usman was showing earlier with the informed consent software is dynamic visuals interfaced with monitoring are critical to ultimately maximize an outcome. And you can see that ultimately this leads to what Usman was talking about. And this has been validated now, or beginning to be validated in the literature, in the world experience in general. This is an excellent pilot study from Oxford showing that with the use of a video consent tool like informed consent, that patient satisfaction scores significantly increased, retention increased, and 85% of patients with the video tool like informed consent would indeed share it with their family and friends, which is very important. And over 80% also reported that the video helped to address their overall concerns and their preoperative expectations and concerns. So again, this was the great benefit of the video tool and the informed consent process. Only added on average about 13 minutes to 15 minutes to the overall procedure. So it's not onerous, and also most importantly, allowed the patient and their family to review it again time and time again at home, at work, on their own, in pieces, should they need to recall and remember the consent process more efficiently. So overall, the personalized video system that informed consent provides would be extremely beneficial to the overall consent process in the United States for the purposes of our medical legal exposure. Thank you.
Yeah, I found that the discussion from both of you very interesting. Things I really haven't thought really a lot about in the past. And Larry, I'm going to ask you, we only have a few minutes left. I want to ask you a quick question, and I think Dawood's going to do the same with Usman. But here's my question for you. You and I had a discussion, you may remember this, in Fort Worth, Texas, a year or so ago. And we talked about how litigious your specialty is and the risk you run. And we have risk as well. And really, I've been asked to look at a lot of malpractice cases, usually on the defense side in most cases. But the question always is, what is enough? What does a doctor have to do? Because we said some patients don't want to know, or they may say, Doc, whatever you say, we trust you, or they may be, always optimistic or always skeptical. What is the standard that we need to, I know this is, you're telling us the best practices where we want to get to, but what's the standard we need to meet?
I think the key is to highlight the critical aspects of the procedure. Obviously, that's the informed consent for the procedure, but particularly because people generally sue when there's an unexpected or unwanted outcome. And I think going over the key complications without excessive detail, because people, again, can't retain or process that, but the fact that you did it, and it's also important when, if and unfortunately a case does occur, to have documentation of that. And a signed paper, unfortunately, is not enough, because the patient can claim they weren't paying attention, they weren't listening, you didn't say it, and so on and so forth. And so that's why having a witness in the room has always traditionally been one way that we've done this, but documenting that witness in the room is also another complex process, because the witness may not have been present the entire time and can't speak to the mindset of the actual patient. So that's where I think I agree with Usman, this informed consent video tool is really a way of establishing the minimum standards to show that we tried our best to give the patient all this information, and the patient, at least for that purposes of that moment, listened and understood, and he was able or she was able to review that later on. And I think that's the bar that needs to be set, because at the end of the day, we can't change people. We can't account for the variable educational cognitive ability of our patients. All we can be judged upon is our effort at delivering the information. And I think that, Tim, is the key bar that we need to set, and where the informed consent software and video tool software like that will play a great role in going forward to help protect us as we try to improve our patients' lives.
That's wonderful insight. I've always had a nurse with me on every consent I've ever done, I believe. So I love that advice. Thank you so much. Talbot, I think you have a question.
Yeah, so really good job by both of our presenters. Dr. Latif, we're challenged. You talk about, someone like Dr. Koo, the busiest surgeon, may do, 5 to 10 surgeries a week. But then you talk about an interventional doc, they may do a couple hundred procedures, injections a week. So how can we use these tools efficiently when you talk about technology to kind of really assess whether the patients are really comprehending this? Because it's a much faster paced environment sometimes.
Yeah, absolutely. No, that's a great question. I've been thinking about that a lot with, every day when we're going out there, we're trying to do all this stuff. We all want, as physicians, to have the best conversation that we can with the patient, so they know exactly what to expect. They know all the things that could go wrong, and they know the likelihood of those things, and so that we're all on the same page and that we're all making a really good decision together. The problem is, no matter how great we are at it or how much we try, it's very difficult to make all those conversations be exactly the same and standardized, right? By using a tool like this, we can be extremely thorough, make sure that every single patient gets exactly the same information. And I would posit that as we go forward, a lot of you know that I have like a lot of background in AI. And I think even with what they have here so far with this product, they're collecting all this data with computer vision, and they'll be able to probably tune a model that can detect when the patient is not comprehending and notify us, right? And so then when you go there, you can say, okay, the patient didn't really understand it. Let's hone in. What did you not understand? What do you want to go over? What can we help with? And so by doing this, you can make it much more efficient, because the majority of the process can actually be better and not require us to be there. We can be consenting someone else while they're watching the video. We walk in at the end and say, okay, what questions do you have for us? And now they had a better consent process, and it was more efficient.
Great insights from both of you. Thank you, gentlemen. I think we kicked this off wonderfully. We'll go to the next panel, but thank you both so much.
Great job.
Thanks, David. Thanks, Usman.
And here we are, Dr. Ankur Patel, Dr. Ken Chapman. Dr. Patel, I think we're handing this over to you at this moment, and then we'll be back. Myself, Dr. Latif, and Dr. Said will be back in a moment.
Great. Thank you, Dr. Deere. So as the other panelist has really alluded to, there's a need for better informed consent practices, right? So this really leads to the question, what do patients really want? And I mean, in day-to-day in clinical practice, patients come in really anxious, they're in pain, they have no idea what's going on, like what the diagnosis is. I think they just really want to be part of the process. They really want to know what the diagnosis is, what treatment options you can offer them, what the expectations, alternatives, the risks, the benefits, kind of really going over that in detail and be part of that active process. But as we know, like that in-office or traditional informed consent process, it has a lot of flaws. And we know the big thing is that the poor recall rate. I think one of the other panelists mentioned that they're less than 25%, patients remember about less than 25% of what's actually given to them on the day of the informed consent in a traditional manner, and that this leads to poor retention and overall poor patient satisfaction. So as like Dr. Latif kind of discussed, there's a need to evolve this informed consent process and to really incorporate multimedia, specific like videos, to kind of make this an active process so patients can really feel engaged, they can ask their questions, they can really see a visual tablet and a visual cue to kind of really help them throughout the process and really able to retain this material and to make an informed decision. So I really want to take a minute and just kind of go over just a couple of studies that kind of really support the use of video and kind of really hone in on these. There was a really great study that was published back in 2018 that had recruited over 3,000 patients, and they looked at patients that were getting in vitro fertilization at that time. So patients for this specific study had watched the videos, and at that time they were actually able to do modules throughout the video. And this assessed both comprehension as well as if the patients had any questions they can actually ask at that time. And then the physician on the other side could see what the comprehension was, if there's any need for any further discussions. And if after the discussion, if they both agreed, the patient will sign the informed consent. And this actually made it more of an active rather than a passive process. And from that study, they found that over 90% of people kind of felt that the media platform itself was very helpful. They felt that they had higher satisfaction rates, that it was more convenient for them, specifically because they could do it at their own time. And the one really nice thing was that a lot of times when patients come to see us, they're with themselves, their spouse. However, there's other caretakers and caregivers that are involved in the process. So they're not available for that. But with this video informed consent process, they can also show the video to other people who may be involved to really make a decision together. And I think that this kind of overall led to higher quality information, and that patients felt like the patient and the physician communication has significantly improved. So I think this is kind of like adds like increased support, not only just like workflow efficiency, but overall patient satisfaction and their overall improvement in being part of an active process with informed consent. So another study that actually when I came across this one, this was actually very surprising. This was a study done based in the UK, and they had found that a small percentage of patients, about 15 patients, had secretly recorded their informed consent discussion with their physician. And then kind of looking at the big cohort within that, about 70% of patients would actually have wanted the video recording itself. So I think this is important because when you think about you're in a large group with many clinicians, how do you really standardize this? I think this is where the application really comes in hand, is that it can really provide patients with the video recording of the informed consent process. However, it really standardizes the material that's given to make sure that there's nothing left out, that the first patient you're seeing for the day is getting the same type of informed consent process as the next patient. I think it kind of really allows that standardization in big practices. I kind of want to take a minute and kind of give it over to Dr. Chapman, who is in a large practice, to give some information about his experiences with the consent process, with the video consent process. Dr. Chapman?
Thanks, Anchor. That was really informative. I think I want to come and give kind of a different perspective on what this program can do to your practice. And just to introduce myself, Ken Chapman, I'm a pain management physician. I finished my fellowship in 2006. And back those were very different times, and there really weren't really any jobs at going around back then. And so I decided to start my own practice, and essentially over that time from 2006 until now, we've had, I don't know, like 20 physicians probably. We currently have over 100 employees, and I'm saying this and I'm bringing this up because one of the major problems that we have, one is obviously going to be our overhead, and two is really, as far as our practice is concerned, is consistency among the physicians, consistency among the advanced practice providers, and really setting up ways to help our providers really practice the same way, which is going to be the safest, not only for our patients, but also for the practice as a whole. With, obviously malpractice, something that's come up quite a bit on this. And that's not necessarily what the, again, it's more just the consistency part, right? And so, and this has to go across all kind of spectrums of our practice. And here is technology, right? And we need to embrace technology, because without it, we're not going to be able to compete very shortly. So we try to incorporate this, and we've done things like this across fields with our practice. For example, urine testing, right? We had some doctors testing, every other month, some testing once every year, some never. And, essentially we created a computer program which essentially standardized the way that we were doing it in a way that was consistent with pretty much all the guidelines out there. So it took the physician part out of it. It took that person potentially messing up out of it. And now we're doing this, and I recommend everybody that is, a healthcare provider on this line, is standardize your templates for procedures to encompass the medical necessity required by Medicare. Because if you don't do that, Medicare is going to be coming back for you. And I can say that because they've audited us like probably 4 times in the last year or two. And my gut feeling is that there's really that they have no money and they're probably trying to come back at physicians. But you know, if you have your notes standardized to meet what Medicare wants, you're going to be good. And so it's hard to do that without standardization. And I know through our providers that the way they get consent is very different, from the bare bones to over the top. You can, worst case scenarios. And you know, having something that takes the physician part out of it with maximum protection has been nothing in my mind but a win. And so that's how I look at this. I think I'm embracing it, because this is what I think is going to help lead us into this next into the future that we're coming up against.
So Ken and Ankur, great discussion. Ankur, we just have time for a few questions. I want to ask you the first question. So, I trained, July 1st will be my 30th anniversary of my practice. So it's been a long time ago. And here you are, I met you when you were a fellow and resident. So it's great to see you out in practice now. What's the future? And when you're in my seat 30 years from now, is AI going to be the way we do informed consent? Do you think is this the beginning, this revolution of really doing a better job of interaction through, video type assistance and facial recognition? Is this the beginning of what we're going to see going forward?
Absolutely. And I think this kind of goes back to what Dr. Chapman said. I think we have to really embrace technology here. I think using technology in conjunction with our clinical practice to really make it not just only efficient, but to improve overall patient satisfaction. And I think as like a recent trainee and like a graduate coming right out, I really feel like that technology is going to really kind of help transform how I'm able to kind of deliver care, like high quality care for my patients, and really to provide safe and effective like outcomes from them. And I think that's kind of like where, when I talk to my patients about using education or using like a different like multimedia like videos and things like that, they really embrace it. They like I think a lot of times patients tell me that they're really anxious because they don't know what to expect. But I think when you use these kind of technologies to kind of take away that anxiety, they feel more comforted. And I think that they overall leads to not only just better outcomes, but better patient satisfaction. So I really think that this is just the starting point, and I'm really excited to kind of see where this goes.
I think you're right. I think you're going to be one of the people leading that. The other person leading that would be Dr. Latif, who has a question for Dr. Chapman.
So, Dr. Chapman, I think you have a very interesting experience because you are both, doing the clinical work like we are, but you're also kind of involved in running this practice, and a pretty large one at that. What do you think in terms of, have you had discussions with, say, your malpractice carriers on any kind of regular basis to figure out if there's ways to negotiate down better rates for your group? And how do you think that this would fit in? If you were working on, home insurance and you get a security alarm, your rate goes down. If you get the security alarm people to monitor your smoke detectors, the rate goes down. So if you did something like this, do you see that bringing it down? And do you see any other potential ways that this could either lead to cost savings or efficiencies within your practice?
Yeah, sure. Well, I think in an ideal world, a world that things are based on merit and credit, this should protect and lower your malpractice. Unfortunately, we're the Spine and Pain Institute of New York, which is a state that is really run by lawyers pretty much, and so I don't think that's going to change our malpractice here. But it does give myself a sense of comfort knowing that, look, I know I can do my job, but I don't know if everyone else can, and I'm sure they can. I don't know if they're giving the effort. So it gives me peace of mind knowing that people that I'm responsible for are doing the right thing. And so, and how could it save money? I mean, it could save physician time, I think. But as far as like, is there a cost savings? I think the real issue is just really the implementation of the, changing the way that your practice works, like that little step of now, all right, we got to give the patient the iPad before we take them to the next step. It's just getting that to be done is really the hardest step. So we'll see, and hopefully it'll lead to cost savings somewhere down the road. But it's more of just, for me, it's just consistency.
Yeah, and I think that's one of those things that hopefully will change with time. I know that there's one physician who's been able to talk to their malpractice insurer, and they're talking about a 5 to 7% reduction. But I think this is one of these things where it starts out small and hopefully it will snowball.
Yeah, I like what Ken said. I think it's going to improve patient care overall, and that's the most important thing. I think places like West Virginia will see reductions, though. I do think our folks will listen to us, and New York City is a little bit tougher, Ken, so I know what you mean. Both of you did a fantastic job, really great insights, and certainly appreciate both your comments and thoughts, and I think we'll see this be an important discussion going forward from both of you. So thank you both very much.
Thanks, guys.
Thank you.
Now to our next panel, I think Dawood would rejoin us here. We have a great panel of advanced practice providers, so I'll have you introduce yourself. We'll start we'll go from the right to the left on the screen. So Casey, you want to introduce yourself, then to Mort, then to Ashley.
Hi, everyone. I'm Casey. So I work with Dr. Chapman in New York City at the Spine and Pain Institute of New York. Thanks for having me.
Hey, my name is Mort Rabii. I'm a nurse practitioner with Dan Kloster in a interventional pain clinic in Overland Park, so basically Kansas City. We've been pretty early adopters of the informed consent application, and as you can see on the screen, we've enrolled plenty of patients and consented plenty of patients with this program.
Hey everybody, I'm Ashley Colmer. I'm from Charleston, West Virginia. I work with Dr. Tim Deere at the Spine and Nerve Center of the Virginias. And thanks for having me.
Well, awesome to have you guys. I'll jump in with the first question for Mort, since you've really had quite an extensive experience with kind of this new technology. So kind of just walk us through, how does it work, from the APP's perspective when you're using this kind of informed consent app for Dr. Kloster to do, say, a radiofrequency ablation procedure?
Sure. So where this really comes into play in our clinic, I don't see it ever replacing the conversation that you as a provider or I as a provider have with a patient. But I go in and I discuss the procedure, what they are going to be having done, go through a very quick description of what they should expect. And then at the end of that conversation, I will have them watch the video, have them interact with the iPad, especially if it's a patient that's brand new to interventional pain or they've never had any of these procedures done. I will also make it a point to make it very clear that I will come back to answer any questions that they have after, so they can absorb that information. I can move on, see my next patient, which definitely helps with the efficiencies, I think, on the clinic side as well. And then I can come back and kind of close that loop of communication with the patient if need be. And I can also know that throughout that entire process that the patient has received a very standardized, very clear education about the procedure that they're choosing to undergo, which sometimes, in a busy practice, as we're all human, sometimes it is hard to consistently give the exact same information, critical information, over and over again.
Thanks, Mort. That's excellent. Usman, you want to kick off with the next question?
Yeah, so this question's for Casey. So I know that you guys have been using this quite a bit in your practice. A lot of times we come up with these great ideas and they all sound great, they look great, but at the end of the day, what really matters is what do patients think about it, right? So do patients like it? And also, some patients, maybe less tech savvy or they may be older. Do you see any kind of differences there, or what has your feedback been from patients themselves?
That it's a great question, because it really is, patient specific, meaning, who's going to really appreciate the technology and the quality of information that you're providing to them. Sure, like it just comes with any, with any practice, that you're going to have some patients that don't quite appreciate it. But really, the goal from our standpoint is to provide them with quality information, streamline our operation, and also to help them to retain the information. And also, I think, we've talked a lot about the technology and what the benefits are, and some of the costs that, the cost reduction for the practice. But, being able to provide them with this information in their own environment is really meaningful, right? And impactful, that they could take this home and listen to it again, and not in an intimidating environment around physicians where they, may not necessarily retain the information, and then share it with their family members. So there are a lot of patients that really appreciate the opportunity to be able to take that home, listen to it again, absorb the information. In our practice, I think that the feedback's been mostly positive in terms of having the information, on this digital tool, and being able to stop it, right? They can ask a question, they don't have to listen to it and then ask, it's flexible and convenient for the patient. So I think the overall feedback's been positive.
I think that's a really good point about them being able to review this information later. So many times I have patients where I spent so much time explaining the whole process to them, and they show up for their medial branch block, and they're like, "Oh, you're not doing the ablation today?" And then we're like, "All right, let's go through this all again." Or it'd be really great if my husband could be here and he could kind of hear on everything that's going on and what we're planning here. So I think that's a good point. I think it's nice to have a durable resource that you can use outside of this.
Yeah, it's funny, it was when I had a patient, they asked me, are you doing the ablation today, who hadn't had their first block yet? So I agree with you. So Ashley, we've had a couple of patients lately. We had someone from Vietnam yesterday, someone from Congo a few weeks ago. But I think, and so those are obviously language barriers. You and I both have a little bit of an accent, I think. The question becomes, we have patients all the time who don't understand our language, our medical language. So, what's been your experience with this informed consent technology to really bring it down to a level where the patient has a better understanding? Has it been helpful in that regard?
So just to echo what Casey and Mort have both said, it has been very helpful. And I don't think I really have an accent, but I digress. So just to break it down, so I think, we as the providers explain it our way, the best way that we can. And then having the informed consent app just reiterates that. And then they go home, they think about all the questions they forgot to ask us when they're in the office. Their relatives, can review it with them and then reinforce things, or maybe their relatives take a different message from it to circle back around and answer a question outside of the office that they might have had or forgot to ask us. So I think, there's a short version and a long version of videos. It's been super helpful. The feedback I've gotten from patients has been very positive. I think once you figure out how to incorporate it into the flow of your practice, based on how many exam rooms you have, just figuring out when to give the video to be viewed while you're going to see another patient and circling back around, or are you doing it at the complete end of the visit and you may not come back in. Once you figure out that flow, then it works very, very well.
So I have a question for Mort. One of the things we think about with all these patients that we see every day is that we're giving them all this information about these procedures, and then sometimes they show up and we do the procedure, and some patients just you never see them again or they don't show up. And my question, I guess, is if we do a really good comprehensive job of explaining the procedure to the patient, but also what risks are potentially inherent in it, what would the impact on that be in terms of either driving up or driving down the percent of patients that show up for these things? How does it impact that behavior? And because I think you guys have used it for so long in your practice, I'm curious what your experience has been.
No, absolutely. It's a great question. In our practice, so just looking at a spinal cord stimulation. So I know that, I feel like that's kind of the procedure where people tend to fall off the bandwagon, right? Because there's many hoops they have to jump through. It's you got to get a psychiatric evaluation. You have to do all this thing, and for some reason, having a piece of electrical equipment in your body, even for a trial, is very intimidating. Even though they signed up for a 10-level fusion without batting an eye. But with looking at our patients, we have, since we've been tracking this with the Informed Consent app over the past 6 months or so, we have had a conversion rate, so to say, of about between 50 and 70% of our patients that have been signed up and consented to a spinal cord stimulation trial have actually gone through and followed through and ended up having the procedure. Nationwide, depending on who you talk to, that average is anywhere between 20 and 35%. So in this very scientific study that we've been doing, we can definitely, I feel like there's a correlation between the patient's ability to have consistent message multiple times over and really have a lot of their questions answered thoroughly through this application.
Yeah, that's really interesting. I think that's also kind of reassuring because we want to give, the broadest kind of explanation of what there is that's going to be done and what the risks are entailed in that, and to know that actually being more open about that and being more thorough about that actually improves the likelihood that the patient's going to go forward with something that's interesting. And I also think it's interesting because a lot of times what happens is patients will look up things on the internet and come in with, oh, I don't want to get, and some very minor thing, and say, because it could, electrocute me, or it could make me paralyzed, and you realize that's actually not even a conceivable side effect of that. And so I think maybe there is benefit to actually just being really, really clear and comprehensive about what is within the realm of possibility.
Absolutely.
Really good points, everyone. I was going to shoot Casey a question. So we've talked about all the good stuff about this and all the advantages. What's difficult? What's been a challenge about this incorporating? Obviously, not too many folks have done it yet. It's not widespread. So what's been kind of some of the difficulties with incorporating this into the practice?
Right. So, as Dr. Chapman said, it's a challenge in, streamlining this into your operations. And, I work for a very large practice that we have, practices that work very different. Like, for example, our Staten Island office has a surgical center, where our New York City office has a fluoroscopy suite where we can sign up patients the same day. Right. So the question is, where does this fit in terms of like how we see our patients? Where's the best place for it? Is it, in the exam room after I see the patient? Is it in the preoperative area where they're prepping them? So the challenge has been also changing our routine in terms of, how we're consenting patients. Not big challenges, right? But it's just a matter of, figuring out and sitting down and adjusting how you consent your patients and implementing it in a very efficient way that not only is going to meet your needs as a provider, but also the patient's needs, right? Because it is a few minutes long, so we do want to give them the opportunity to not feel rushed when they're watching it as well. So that's been a little bit of a challenge. And then also, there's also the challenge with some of the patients that are, in New York City, everybody's in a rush, right? Nobody wants to take a minute to listen to this. So encouraging the patients, to really take this opportunity to listen to it and ask us the questions that they have after.
Great answer. Ashley, we have just a few seconds left. So last question for you. Do you think this, for patients, is this a better tool than what we have done for the last 29 years?
So I think it's a great supplementary tool. We can never get away from giving the information, giving our own individualized explanation of expectations. And this is a great supplement to take home and have that, whereas they wouldn't have that before. So I like it. The feedback, like I said earlier, has been great. I think moving forward, just them having the ability to go home and have this to look back at and really retain that information is critical.
Great answer. Thank you all three very much. Great job. We were into our last panel now. And that's attorney. I have attorney in my family. I have a daughter who's an attorney and a daughter in law school. So Bruce, I'm very familiar with your crew. And we love to talk with you a little bit about what we spent the last 45 minutes on. So we're gonna launch a question. I think Dawood Sayed has a question for you to start this discussion.
Yeah, Bruce, thanks for joining us. This is really going to be probably my section of this talk that I've been looking forward to the most, to see an attorney's perspective on this, because it's much different than a physician's and maybe even a patient. So you've kind of tuned in and listened. So what's your just kind of mile high view of kind of using this type of tool in kind of the consenting process as far as the medical legal kind of implications?
Okay. As it says, I've been doing this over 40 years. That means I'm not very technological. I apologize. So the broad overview and the most important thing from a legal point of view is that this video that's saved with a patient looking at a complete and competent and standard of care informed consent discussion and proof that they saw it is, in my mind, irrefutable proof of appropriate informed consent. And as was said, 25 to 60% of suits in the specialties involve, at least in part, informed consent issues. And plaintiffs' lawyers, who I've been dealing with for over 40 years, they're not in the business of losing money, and they don't take on losing cases. And I can easily envision a physician or his lawyer or her lawyer or the insurance company getting a claims letter from a plaintiff's lawyer, sending over the informed consent video, and nothing else happens. It all just goes away because it's irrefutable proof of appropriate informed consent, and you just don't get that from paper. I'm now going to take a point of order before you ask me the next question. With due respect, and this is probably why everybody hates lawyers, but the word is litigious, not litigious, as you gentlemen have been saying. So try to say litigious. And the second thing, and it only occurred to me tonight, I've been exposed to the informed consent product in its formation for over a year. But it occurred to me watching this tonight that one other benefit is that with respect, most of you folks talk too fast, and patients come away from your discussion thinking you're in a hurry, and you're really not. You just talk too fast. But the videos that I've seen are presented more at a pace. I mean, people are used to listening at a certain pace, and you guys are used to listening to each other, so that's fine. But when your patient comes in, they're not used to how fast you talk, I'm telling you. And that meant, I don't know if that's even a minor point. It might be a medium-sized point, that these videos are presented very professionally. Not that you're in the room would not be professional, but I think it's just more understandable. Of course, they can watch it several times. They can watch it with their loved ones. They can send it to their daughter in law school that's across the country to look at, or whatever. But to get back to the point, the main thing, and there's other benefits that I wanted to mention, but the main thing is it's irrefutable proof that the informed consent process did meet the standard of care. That's the main thing.
So Bruce, great points. I'm going to have a question for you. Then Dr. Lateef has a question for you. So, I'm glad I didn't try to use the word litigious tonight. That wasn't me. But I will say to you that, I think it's important we speak in correct taxonomy. I've corrected a lot of lawyers in depositions using medical terms. So thank you for that. My question for you is a little bit different. And that is, Larry Koo spoke earlier, who's a neurosurgeon at UCLA. And he said neurosurgeons get sued about every 9 months. And, thankfully, that's not as common in our interventional spine space. But in my experience, and I've been involved as an expert in many cases, informed consent is really an issue a lot of times because someone claims it was a common complication, and it turns out it was a very, very rare complication. So it wasn't in the form. So my question for you is very simple. What is the standard for how often something occurs? Like if 1 in 1 million people get something happen to them, should it be in that form? Is it 1 in 5,000, 1 in 10,000? How often should a complication occur till it reaches a standard it needs to be in your informed consent?
Well, obviously there's no numerical right answer to that. And in every jurisdiction that I know of, it's just what is the standard of care in the community. And so giving you that wiggle room, I won't give you numbers as 1 in 10,000 or 1 in 5,000. I'll give you numbers as into the 5 most common complications. Even if number 5 is 1 in 10,000, I would say put it on there. If the 5th one is 1 in 100, I don't think you need a long list. I tell physicians when I speak to groups, it's always going to be the one right below the last one you listed, because that's just the way it works. But my rule of thumb when I'm asked that question is I give my disclaimer, and then I say list the top 5. I have no articles, no empirical data that you get sued less if you do it that way. That's just, I've defended thousands of these cases, and that's just kind of what I've come up with.
Great advice. Great advice. Dr. Lateef?
Yeah, that's really interesting. So, my question is around this. We saw a lot of these studies where people are surreptitiously recording, their interactions with physicians. I think a lot of people are nervous just in general, regardless of whether you're a physician or not, about being recorded for things. What do you think in terms of, is there any downside to recording these consent discussions?
No, I really don't think so. But your lead-in reminds me, I once had the honor of defending a physician who made inappropriate advances to a patient who was recording the visit, and she played the recording on Oprah. Those recordings do happen. That case did not go to trial, by the way. But I just don't see a downside. Of course, they have to agree to do it. There's one little, people haven't mentioned this yet, there's another little consent that comes into this, which is this iPad is going to video you watching the informed consent process, okay? Because they have the right to say, no, I don't want to be videoed watching this, in which case all the informed consent physicians have a plan B. So since you have a plan B, I don't see a downside to plan A if the patient says, yeah, I'll do plan A. So I really don't see one.
That brings up a good question. So, well, Bruce, what if the patient says they're not going to sign it? As us as a physician, are we leaving ourselves open? We're like, well, I'm not going to do your procedure now because you're not doing this.
Well, it's the same. It's no different than the paper informed consent. If they come and they come for their elective procedure and the piece of paper is put in front of them, they don't sign it, your hands are tied. If you do surgery on them without them signing it, you've committed a battery. So you've got to get the informed consent. And if they don't consent, they don't consent. Emergency situations are beyond the scope of what all we're talking about, because you don't show a video to informed consent, to emergency patients. But yeah, in the elective surgery realm, if they don't consent, you just don't do it.
So Bruce, let me ask you a question about something that has been brought up a moment ago. You know, we have patients who sometimes bring the recorder and say to me, can we record this conversation? So I actually just grab the recorder and actually talk in the recorder, because, you know, I'm going to say, I consistently say the same thing about certain procedures. But one of the questions that comes up sometimes, let's say, for example, Dawood and Usman come up with a new procedure that's brand new, and they get some FDA approval, and they're going to do it. And one of the things, you know, we're told we need to talk to the patient about is the other options. You know, what else could they do as part of the informed consent process? You know, what's the standard there? Is it commonly done things? Because there's, you know, some treatment like knee pain, there could be 50 different things you could do for knee pain. What is
it all comes back to reasonableness again. Another thing I wanted to mention, and as the nurse practitioner mentioned in the last panel, there always has to be some face-to-face involved, because for one reason, there could be new information. These informed consent videos are videos that are updated from time to time, but a new procedure might come out and the physician might just have to come in and say, in addition to what's on the video, we now have the DEER technique, which is not everybody's doing it, but it's available. So I want to talk to you about the DEER technique, and you just have to do that face to face, if that answers your question.
Fantastic answer. Thank you. I know it's very helpful.
So I have another quick question here. So, you know, we talked a lot here about what is kind of the core or the crux of a lot of these suits, right? So most of them are around complications. So it seems intuitive that informed consent would be a key role there. The data that we've looked at seems to suggest maybe it's in the 50 to 65% range. So my first question is, you know, do you feel like that's consistent with what you've seen in your 40 years of practice? That is it really the case that informed consent forms kind of the center of a lot of these suits? And then my second, I guess, kind of tag on question to that is, if you had a single piece of advice to give us as physicians with others, what would it be?
Well, I get asked that a lot at seminars, and the easy answer is stop taking care of sick people. Just see well people. But no, that I'll have a better piece of advice at the end of that. But in my personal experience, and I've defended more general practitioners and specialists, I would say roughly 20% to 25%, the main, if not sole, allegation was lack of informed consent. But close to half the time, informed consent is part of it. I'm not saying they would not have filed suit otherwise, but yeah, a vast majority of cases are complications. And let me sneak something in the side door, because Dr. Koo said something that I thought was very important about patient satisfaction. And when you're doing informed consent process, there's going to be two audiences that are going to be important. The first audience is the patient's family. If the complication happens and they've gone through an informed consent process where the physician shows that she is caring, she's competent, she's given a complete explanation through the video, and then afterwards, if the complication happens, in my opinion, and I've seen this happen, the patient is much less likely to sue, because they say, hey, they tried their best, but there was a complication. But then the second audience that you try to avoid, but the second audience is the jury. And if the jury has shown this video informed consent process with proof that the patient watched the whole thing, and when they turned away from the camera, it paused, the jury, I think, will think, well, what more could the physician do than this? I hope that kind of answers your first question. My one piece of advice, and all you folks on the panel tonight have shown it, is even though you're extraordinarily busy, you have lots and lots of things to do what you can to establish rapport with each patient. You have no idea how important that is. They might even heal better because they trust you more. Do what you can to establish rapport with each patient. If I had to say one thing, that's what I would say.
Bruce, that's great advice for all the young doctors and residents who will watch this video later. I think that's wonderful advice. What a great way to end this session here. Thank you so much for taking your time tonight. You've been very, very valuable to us, and we greatly appreciate it.
Okay. Let me see if I can figure out how to go away.
Dalwood, I think you have a few announcements to make, and then we'll give Usman the last word of the night.
Yeah, absolutely. So I think we have some information here for those that are going to be watching this here now live. There's a QR code to get more information on the Informed Consent app. We have a couple other programs coming up. We're going to have a Young Innovators webinar on sacroiliac joint disease diagnosis and management coming up November 29th. At the time there, if you click on that QR or take a picture of it, you can register. Can't believe it, but it's time to start calling for abstracts. So time is now. We've really already hit the ground running on planning for the ASPN 2024 meeting in July. So it's going to prove to be even bigger and better. We say that every year, and we've kind of delivered. So hope everyone can kind of join us. It starts with really people presenting the best science in the world. And that's really what we've done the last couple of years with having these podium presentations with really some exceptional research. So those of you working on research, whether in industry or academic centers or private practice, please send it our way for consideration at a presentation at what I think is the premier pain and neuroscience meeting in the world now. Tim?
Yeah, I encourage everyone to go put that on their calendars tonight, July 11th to 14th. You may want to come down the 10th and leave on the 15th, but it's a phenomenal meeting. And, I think you might want to go ahead and book a room there because it'll fill very quickly. There'll be a Aspen block there. And then last year we had to go to 2 other hotels. So please join us and really have the camaraderie and what we call the Aspen family. And I think it's very important that we support each other across diverse groups and wonderful people. With that, Dr. Lateef, we're going to give you the last word of the night. Give us a summary of what we discussed tonight.
All right. Yeah, I appreciate everyone joining us today and all the great panelists here. I feel like, when I step back from this, really the thing is this. All the time we want to do more for our patients. All the time we're asked to do more for our patients. And yet we have a limited amount of time and we're trying to make all this happen. And I think one of the really exciting things right now is with how much technology is progressing, it is now gradually becoming more and more possible for us to do more and to do it more efficiently and to do it more consistently and to do it in a way that is actually practical. And so that's why I found this discussion really great. I think this product is really interesting, and I'm excited about all the other things that we're going to see in the future that will help to improve the patient experience for all of us using technology.
Good night, everybody. Thanks for joining us.
Good night.